Okay, so let's talk about a transient ischemic attack. So it's saying ischemic, meaning there's been a brief blockage in a artery or a small capillary somewhere in the brain, and then it resolved. Transient ischemic attack, a TIA, versus a stroke, which is permanent. There's been cell death. There hasn't been any cell death with a TIA. Okay. Luckily, the blocked artery was able to clear the occlusion. So whatever it was, say it was a small embolus or a bit of atherosclerosis that temporarily blocked the artery, and then the artery was able just to continue and open the vessel once it cleared. Okay, so it's a brief blockage of a cerebral artery, and it gives stroke symptoms because where that artery was supplying blood to the brain will determine what the symptoms were. Okay, so let me give you an example. If you have your blood vessels that are feeding the left part of your motor cortex, okay? So say there's a blockage in the artery that's feeding a portion of your motor cortex and you get right arm weakness or paralysis. And it lasts for minutes and then suddenly resolves. Well, that's a TIA, right? It could be facial paralysis. Okay, so it could be, again, blockage of an area in the brain that supplied motor nerves to your face. So you have loss of function of your facial muscles on the opposite side. You can have a TIA to your eye. So if you have a clotted artery that is just briefly blocked and manages to reopen by itself, then you can have sudden blindness in one eye that then resolves within minutes. And we call that an optic TIA, right? So TIAs are important because when someone comes in and says, you know what, I had weakness to my left arm, I couldn't move it, but now it's completely better. Well, that's a warning signal that they're at high risk for developing a stroke in the near future. And that's why we do an assortment of tests if someone presents with a TIA. Okay? So a TIA could be from local thrombosis or atherosclerosis that managed to reopen, luckily, or from an embolus that the body was able to dissolve and clear the embolus. Again, luckily, right? Since it didn't cause a stroke. So we used to call transient ischemic attacks, we used to call them mini strokes. But that wasn't very accurate because then people would then think that they'd had a small stroke. And they really hadn't had a stroke since they didn't have any death of neurons. Okay? So really think of a TIA as a warning signal that the next event could then be a stroke. Okay? And there's been no permanent damage from a TIA. Okay? The blood vessel was able to open and continue normal blood perfusion. Okay? We typically put people on antiplatelet medications or anticoagulants when they have a TIA to stop their platelets from sticking together and potentially leading to another TIA or even a stroke. Okay, this slide on transient ischemic attack, I think we'll be able to go through it relatively fast. We've mentioned what it is already. Also mentioned that if you have a TIA,
you're definitely at risk for getting another TIA or even a stroke within weeks to months. And that's why someone who has a TIA, we're relatively fast. Usually, while in the United States, you often get admitted for a TIA for a workup to find anything that is reversible before you get another TIA or a stroke. Because we know that around 15 to 20% of TIAs will result in a stroke, and that's going to cause significant disability for that patient because it's not reversible. So you really can't tell at the beginning. If someone presents within minutes to a hospital with TIA symptoms or stroke symptoms, we don't know if it's a TIA unless it resolves within typically an hour. If it resolves, okay, it's a TIA. If it doesn't resolve and the symptoms persist, then you have a stroke. It's not reversible. We treat them as a stroke when they come in because we don't know if it's going to clear up, and that's why patients get an urgent CAT scan to see if it's a hemorrhage versus whether we think it's an ischemic stroke. So there's a very fast workup when someone comes in with neurological symptoms that are either a TIA or a stroke. So what do we do? So first of all, so we're at where it says TIA symptoms last several minutes, and that's true. Most of them clear up within minutes. Some of them can take an hour. We actually used to say that a TIA can take up to 24 hours, but we've removed that from the guidelines. The vast majority clear up within 1 hour. So what do we do? Well, we'll do brain imaging, typically with a CAT scan. And why do we do that? Well, if someone presents with a TIA that's now gone, they have no symptoms now, we'll do a CAT scan not to see if there's damage from the TIA, because we know that there isn't going to be, because they're back to normal. But we're going to see, has there been any previous strokes on the CAT scan or the MRI in the past, from years ago or months ago? We'll do an ultrasound of the arteries of their neck, a carotid Doppler. Why do we do that? Because if we see a very critically blocked carotid artery, that is fixable with surgery, with what's called a carotid endarterectomy, where they'll go in, they'll open the neck, and they'll clear out the blocked artery so that you don't get a stroke in the near future. So a TIA will definitely get you a carotid Doppler of the neck. What about an echocardiogram, which is an ultrasound of the heart? Well, we definitely want to see if you have any clots in the chambers. And typically you don't, but you can have clots forming in one of your chambers if you have irregular rhythms. And by far the most common one is atrial fibrillation, where the atria are contracting very irregularly, and that puts you at risk for forming clots in them that can then travel to the brain. So we'll do an echocardiogram to look at the chambers of the heart. And also, don't forget, you can have holes in your heart that I think we covered in cardiovascular. You can have a foramen ovale, where you can have clots traveling from the right side of your heart to the left side of your heart that then can give you a stroke. So an echocardiogram is definitely part of a workup for either a stroke or a TIA. An ECG we do because we want to see if you have atrial fibrillation, because we know this condition puts you at risk for forming clots in your heart. And then we do some basic blood work to see just to see your hemoglobin, to see your white blood cell count, to see your platelets. For example, if your platelets are extremely high from some kind of bone marrow problem, or your hemoglobin is abnormally high from some bone marrow issue, well, that can really thicken your blood and put you at risk for a stroke. Those are rare conditions, but we'll do them just to check them at the beginning. BMP is for basic metabolic panel. That would be electrolytes and kidney function. That would just be part of the regular workup. INR is just to see that you're clotting normally.
Okay, so let's do this slide together. So a patient has left-sided weakness of the upper and lower extremities. Okay, so their arm and their leg on the left side has become suddenly weak. The symptoms lasted less than an hour and resolved. The patient most likely experienced, well, in a hemorrhagic stroke, that the blood that's left the artery hasn't resolved at all. So that's not going to happen. That won't be the answer. And especially the term stroke, right? Stroke means there's going to be some permanent damage. Okay, transient ischemic attack. Well, the symptoms have completely resolved. Neurologic function has returned to normal. That is really classic for a transient ischemic attack. Okay. Episode of hypertension. No, an episode of hypertension is really an intravascular issue, right? You have high blood pressure in your arteries, but it's not causing these symptoms. A stroke caused by an embolism? No, because you would be left with ongoing symptoms of left arm and left leg weakness. So that wouldn't be the answer. So the answer is B.
So this slide is signs of stroke. This is just a quick, there's all kinds of mnemonics and reminders, and for people in the community to remember, just to help decide, should I call 911? Should I call someone for help? So this one, be fast. So balance. Definitely if you've had a sudden loss of balance, or you suddenly get a severe headache that's completely out of the ordinary, or you're dizzy and you're not able to walk anymore. Okay, that's a good reason to looking for help. Eyes. And we mentioned this before, if you suddenly have loss of vision in one eye, that would be concerning for either a TIA, hopefully it'll resolve, or a stroke, an ischemic stroke. And if it's an ischemic stroke to the eye, and really you should consider the eye as an extension of the brain, because the optic nerve, which leaves the eye and goes back to the brain, is part of the nervous system. So loss of vision in one eye can be an indication of a stroke. Face. One side of your face is drooping, so the facial muscles aren't functioning anymore. That can be an indication of a stroke, or sometimes something much less benign called Bell's palsy, where the peripheral nerve, the cranial nerve, isn't working temporarily, and you have unilateral, so one side, facial paralysis. So facial paralysis on one side of your face can be either from a stroke or from Bell's palsy. Arm or leg weakness on one side. So usually we're not thinking of a stroke if it's both sides. If both arms are weak or both legs are weak, that's not usually a stroke, because that would mean you'd have to be having a stroke on both sides of your brain. That would be very unusual. But unilateral, so one-sided arm weakness or leg weakness could be a symptom of a stroke. Speech difficulty, so confused speech, sudden onset, garbled words, inability to be understood, can be a stroke in the speech center on the left-hand side of your brain. And lastly, okay, if you're getting one of these symptoms, maybe it's time to call for help. All right, stroke risk factors. So stroke risk factors are basically the same as risk factors that damage your artery anywhere in the body. So whether it's the coronary arteries or the peripheral arterial disease, so the arteries going to your arms and legs. So because the underlying problem is atherosclerosis, which is the biggest risk factor for getting a stroke. Because remember, 85% of strokes are from atherosclerosis or an emboli. So what factors are just not modifiable? You can't change these. You're born with them, or so your age, your sex, your ethnicity, family history of strokes or TIAs, and of course your genetics. So these things are just not modifiable. They're just part of your makeup. The modifiable, so things that you can change to reduce your risk of stroke. Definitely hypertension is #1 modifiable risk factor for reducing your chance of stroke. For 2 reasons. So the first reason is hypertension is a significant risk factor for a hemorrhagic stroke. Makes sense. You have high blood pressure in your arteries. That puts you at risk for rupturing one of those arteries, especially if one of the arteries is weak. The other thing is hypertension is a risk factor for damaging the arteries over time and leading to atherosclerosis. So it's a risk factor for hemorrhagic stroke, and it's a risk factor for atherosclerosis, so thrombotic stroke. Smoking, well, smoking, when you're a smoker, you're actually inhaling a lot of chemicals into your bloodstream. And those chemicals are harmful to the lining of the arteries. And that's one of the initial events that leads to atherosclerosis and plaque formation. So smoking is a risk factor for atherosclerosis. Diabetes, same thing, damages blood vessels over time. Atrial fibrillation is a risk factor for forming clots in the chambers of your heart, which you can then embolize and have an ischemic stroke from the clot that has traveled to your brain. And that's one of the main reasons why we put people on blood thinners if you have atrial fibrillation, to prevent the formation of clots within the chambers of the heart. High fat diets, refined sugars, so poor diets can lead to a number of changes in your body, but they can lead to atherosclerosis, right? High fat diets will lead to atherosclerosis, and so will diets very high in refined sugars lead to atherosclerosis and plaque formation. Activity level, very active. Your arteries like having blood flowing through them normally. So a sedentary lifestyle, not very active, is a risk factor for atherosclerosis in the arteries of your brain, your heart, your legs, all over the body. Okay, typically if you have atherosclerosis in one part of your system, say your coronary arteries, and you've had a heart attack, you very likely have atherosclerosis in all the arteries of your body, whether they go to your kidney, your legs, your brain. You just haven't had symptoms or anything happen from those organs yet. And lipids, so cholesterol and abnormal lipid levels. You know, if you remember LDL, which is, quote, the bad cholesterol, and HDL, which is the good cholesterol. So high LDL levels is a risk factor for atherosclerosis. Okay, so all these risk factors are really about accelerating the formation of plaques in your arteries that will then finally lead to a blocked artery. And of course, hypertension, don't forget, can also lead to a ruptured artery, a hemorrhagic stroke. So let's look at some of the effects of a stroke. Uh, that's the medical term for it. You can call it a brain accident or a brain attack. But it's either a stroke or a cerebral vascular accident. So on the left-hand side, so a headache. Headaches are typical for a hemorrhagic stroke. You don't often get, and that makes sense, right? I mean, suddenly you have more blood that's taking the place of brain tissue. You're going to get a terrible headache. You don't typically get bad headaches with an ischemic stroke. Uh, there's not increased volume of anything. You just have a blockage of an artery. Mental changes. So if you're having a stroke of a part of your brain, well, definitely confusion, disorientation, memory impairment, long-term or short-term can occur. Aphasia, that's typically on the left hemisphere. So aphasia means inability to form words. That's a motor aphasia, inability to form words and sentences. And a sensory aphasia would be inability to understand words and phrases. So either one of those can happen. You can imagine how frustrating that would be to know what you want to say, but you can't form the words and the sentences to get it out. Respiratory problems. So if you've had a significant stroke, you may be impacting your ability to breathe or to cough properly, to take big breaths and have a good cough. So the neuromuscular function to the lungs is impacted. The next one is agnosia. This is the inability to process and understand information. So you may not recognize objects. You may not recognize people or shapes or sounds in your environment. So you have agnosia. Incontinence, so urinary or fecal incontinence from lack of control of the bladder or the bowel. Seizures. Well, if you've had a stroke, you've definitely had some scarring formation in the brain of where it healed. So you can develop chronic seizures after a stroke. Hemiparesis or hemiplegia. Well, that's the same. Hemiparesis and hemiplegia are the same word, right? Or same meaning. Meaning half of your body is paralyzed or affected. Emotional lability. After strokes, people often have depression, anxiety, tearfulness. They can be up one day, they can be very depressed the next day. So they're emotionally labile, they're up and down. Visual changes. So the optic nerve from each eye goes back to the brain, and it does the fibers partially cross over to the other side of the brain, and some fibers stay on the same part of the brain. You would have to look at a nerve map. It'll be too confusing for me to explain it on an audio. But you can have visual changes where part of your visual field is completely knocked out. And it's usually in both eyes. So a visual field defect can be part of a stroke. Horner's syndrome is a condition where the sympathetic nerves have been damaged that go to the eye. So you actually have a constricted pupil, miosis. You have a droopy eyelid, that's ptosis, which is written there, and you have absence of sweating of that side of the face. So it's those three characteristics that make up Horner syndrome. Vomiting. So these symptoms, by the way, are kind of a mixture of chronic symptoms that you have for a long, long time and acute symptoms. So, for example, the first one was a headache. Well, that would be an acute symptom, sudden onset of a headache. A lot of these other ones they're chronic over years that you just have them. Vomiting would be an example of something that happens suddenly. So you suddenly get a headache and vomiting out of the blue for no reason. We might think that you have a hemorrhagic stroke. Perceptual defects. So the right hemisphere is heavily involved in perception and how the environment is perceived. So strokes in that part of the brain or on that side of the brain can give you perceptual defects. Hypertension, again, we're back to more of an acute symptom. So people that have sudden onset of strokes can develop severe hypertension, and that's the body's response to make sure that the blood continues to get to the brain after a stroke. Apraxia is movement difficulties, so inability to perform your typical movements with your limbs that you've learned over many, many years. So that's apraxia. Okay. At the bottom, there's a chart on TIAs. Remember, the TIAs are very brief, minutes, rarely more than an hour, and definitely not longer than 24 hours. So it's usually minutes to less than an hour. And people can present with confusion, brief episode of confusion for 20 minutes, brief vertigo where the room is spinning that suddenly goes away. So an old person where the room is spinning and then it suddenly goes away. That can be a TIA. Dysarthria, they were talking to their friend and suddenly they had slurred speech. They couldn't get their words to pronounce well because of the muscles of their mouth. They weren't contracting properly, so they have dysarthria. Transient hemiparesis, that's just basically, I couldn't move half my body for 20 minutes. Okay, I'm concerned about a TIA. Temporary vision loss, we mentioned that before. That can be a little clot in the retinal artery that then breaks up and goes away, and luckily you get full vision back. The little box at the bottom, focal neurological signs and symptoms. Okay, so focal meaning, okay, focal means something that's happening in one discrete area. So focal paralysis. So if you have focal paralysis of your right arm and right leg, okay, that's very concerning for a left cerebral stroke. Focal sensory loss. So suddenly you lose a sensation in your right cheek, right arm, and right leg. That's concerning for a left cerebral stroke. Focal language disorder. So you lose the ability to speak, to even remember words that you want to say. That can be an acute stroke in the speech center, which is the left side of your brain. Reflex changes, I think we'll get to a bit later. They're not really critical. Usually when you have a stroke on one side of your body, the reflexes initially, or the reflexes become hyper-reflexic. So when you use a reflex hammer on someone who's had a stroke, you'll notice a big difference when you check their knee reflexes and their elbow reflexes. They'll be hyper-reflexic on the side of the stroke. Okay, so this slide I'm not going to spend too much time on. Just remember that the left hemisphere is where you have your speech center. So it's where you have the reception of the words that people are saying. So to understand sentences that people are saying to you. So if that's damaged, that would be a receptive aphasia. If the motor part of the brain that you send out sentences is damaged, that's an expressive aphasia, meaning you're not able to make sentences and to form words in your brain. So there's one where you can't understand the sentences coming in, that's receptive, and there's one where you can't make sentences yourself because of the damage to the speech center. And then there's global aphasia. So you don't understand what anyone's saying and you can't express what you want to say. And the rest I'll leave for you to go through. It's just it's a matter of just remembering. I'll tell you another one: mathematics, acalcula. There should be believe it or not, there should be an extra C in acalcula. And this is from the Heart and Stroke, by the way, too. So mathematics is a left hemisphere function. So if you have a stroke, you can lose your ability to do mathematics. Agraphia is the ability to write properly, and in your normal writing, that's a left-sided function. So just look through these. There's differences between whether you've had a left-sided cerebral stroke or a right-sided cerebral stroke. Okay, and here's another nice example of what can be damaged and what symptoms you might have depending on whether the left hemisphere or the right hemisphere of the cerebral cortex has had a stroke. So on the left side, well, if you've had a left-sided stroke or a left hemispheric stroke, your right hand and your right leg is going to be affected. Remember, the speech center is on the left, mathematics is on the left, scientific functions and calculations, left-sided. Writing, we mentioned before, is on the left. That was agraphia. And reasoning is a left-sided function. Look at the right-sided hemisphere. I feel like I'm missing some of these already. So it controls your left hand and your left arm. Sorry, your left arm and your left leg. Spatial orientation, music, artistic functions, art awareness, creativity, all right-sided functions. Now that I've read this, I'm quite sure that I'm missing some of them on the right side.